97.1 FM Talk Podcast.
This is Eye on Health with Dr. Michael Jones.
Hey, welcome back. It's Eye on Health. I think.
It is.
I was running a little late today. Wasn't I?
You're not out of breath, though.
That's right.
It wasn't like a marathon or something where you had to park down by the arch.
No, it wasn't that. No. Just poor time management, which would actually fit in very well with our guest today. Dr. Joe Ojile from Clayton Sleep Institute.
Yes. Good morning.
Good morning. Thanks for coming back in, Dr. Joe.
It's always great to be here.
And Dr.
I was
Joe,
happy you didn't oversleep, by the way.
I wasn't oversleeping. Well, I did oversleep a little bit. You're right. He got me. Well, Eye on Health. My name is Dr. Michael Jones. Every Saturday, 10 to 11, we're talking about your health with my partner, Eric Robert from...
Well, Redbud, right down the street from Quantum Vision Centers.
You haven't moved yet, huh?
I have not, no.
All right.
We've got a baby coming in.
Okay,
in about
right.
4 weeks, and so
really?
Yeah.
Holy
Yeah,
cow.
that went fast, huh? Tell me about it.
This is number 4?
Number 4. The minivan is full.
Man.
Yeah. Busy time.
Get up to the basketball team when you get to 5. That's good.
Yeah,
Well, if you need me to teach them how to play basketball, we're going to be waiting a while.
But you could have a whole accounting department.
What's that?
A whole accounting department.
Hey, there we go.
With 5 kids. Yeah. All right.
One for,
so 4 weeks. And I remember we broke the news on this show.
We did, didn't we?
It's been that long?
Yeah, it has.
Oh, goodness gracious.
Yeah.
All right. Well, so 4 weeks. Are you worried, nervous, excited?
No, well, fourth time around, you kind of...
Yeah, right. Are you even going to be there?
Yes, I will be there.
I'm sure when your accountant brain kicks in and you're doing all the charges and everything while it's all going on.
Yeah.
Yes?
I've, just to help lessen the blow, I have intentionally not used any of our severely limited flex spending thanks to the Affordable Care Act, just because I would like to be able to use all of it at once with the hospital bill. Makes it feel a little better at the time.
Doesn't sting quite so much.
Yeah, even though it's $2,500 here or $2,500 there, decide when you want to spend it. But
I mean, I haven't been through this in a while. Neither has Dr. Joe, I'm sure. But I can imagine having a baby has got to be an expensive medical venture.
It is, and having had,
I like how that's said.
Having gotten to experience this several times over the last 4 or 5 years, healthcare costs are rising. And they seem to rise.
Wait, I thought the cost curve was bent.
Yeah,
Didn't
yeah.
it bend?
It bent.
It bent something.
Yeah. It bent.
It bent you over.
Wrong direction. Yeah, there you go.
All right.
Yeah.
All right. Well, Dr. Joe Ojile's back again. Dr. Joe, frequent guest from Clayton Sleep Institute. What's the website? I don't remember it. I was running.
ClaytonSleep.com.
Oh, I see where you came
That's
up with
a
that.
nice succinct.
That is.
If we're a medical practice, that's about as short as they get.
Yeah, some of the websites we get are a whole sentence.
So's the sleep doctor, about as short as they
There
get.
you go. Yeah.
And the phone number.
314-645-5855.
And Dr. Joe, really a national expert on sleep. He's been in multiple times to tell us about all sorts of things related to our sleep. And I think every time he comes in, Eric, he amazes us with how sleep is really integrated into almost all of our lives, which is really a relatively new thinking for medicine. At least even when I was going through my training, sleep was a mystical, it wasn't something that was in the core curriculum for student doctors, that's for sure.
Sure. And in medical school, less than 1 hour in 4 years of sleep training for a third of our lives.
Right. Amazing.
It's amazing.
It's
isn't it?
amazing. Yeah. And I really like how you've told us every time you come in which different disease processes this sleep or lack thereof integrates in, including one that's near and dear to my heart, glaucoma.
Yep.
And we just finished Glaucoma Awareness Month.
Yeah.
And we had their glaucoma doctor and we didn't ask him about sleep.
How aware were you of glaucoma?
Extremely aware. Yesterday, when I was extremely aware of glaucoma yesterday. Yes, I was.
That's in your sweet spot, so to speak.
Yes, right. That's right.
What's so interesting about having you on, Dr. Ojile, is Dr. Tobler has told me before, this is anecdotal, of course, but he's 80% of medical issues, if you just dealt with sleep, nutrition, and exercise and got those straightened out, almost everything would go away. And we spend so much time talking to specialists about very, acute symptoms and specialized issues, as you would imagine. But really, sleeping, eating right, and exercise for the vast majority of the population, that's what we got to get down.
Absolutely, yeah.
It'll make us have a better life. And actually, even in Dr. Tobler's area, it's really exciting in obstetrics now. There have been several good studies in the last few years, and this is and those of us in our team have had a real interest in this for a while, is that the group out of Northwestern has done several studies now looking at the effects of sleep-disordered breathing, sleep apnea on pregnancy. And our theory is that since obstructive sleep apnea drives blood pressure and things like stroke and so forth, is there risk to mother as you increase the fluid volume to the back of their throat. They're, of course, carrying a baby and so forth. So all these anatomical changes. And what they found in several studies now is it's clear that some pregnant women will develop obstructive sleep apnea during the course of their pregnancy, even if they weren't diagnosed in advance. If they were undiagnosed and had it, of course, they're at very high risk. And then, in turn, it appears to put them at risk for increased high blood pressure during pregnancy and increased blood sugar.
Interesting.
So you're getting more, and of course, the thing is, those young ladies and babies, injuries or diseases to them are very damaging for both them, their families, and the long-term health cost and expense to our society because they're so young.
Oh, sure, absolutely.
That's an interesting, exciting
pretty amazing. I think maybe last time or 2 times ago, you were even saying that it's not uncommon now to have temporary CPAPs or CPAP during pregnancy just to kind of get you through it, which I'd never even, considered such a thing.
Yeah, and we put them on an auto-adjusting device, so as their bodies change, they don't have to worry about getting a new pressure set and so forth. It's an exciting development, and it gets into that whole kind of wellness space. This week on the news, I was just mentioning that Mike Napoli, the very well-known I think catcher for Boston.
Don't ask Eric. He won't know.
Yeah, so
he want to know.
But he's had quite a career.
Yeah, right.
He is at the peak of his career, and they reported this is after the fact.
Yeah, relatively young guy. I mean, he's been around a while, but he's still got
30, 33.
Still has years to play. Sure, right.
In medical terms, he'd still probably be in medical school, training.
That's right.
So but he was having trouble falling asleep in the dugout. Was having to come out of games early because he couldn't stay awake.
Yeah.
All these sorts of things. He went and got evaluated. He had very severe obstructive sleep apnea. And in turn, he took an interesting approach, which is he had his jaw surgically reconstructed.
Right.
So quite a significant, severe surgery. We do have that technology available in St. Louis, thankfully. Not many patients choose to go that route. They have to have the right anatomic structure, typically a set back lower jaw. But they actually fracture your jaw under general anesthesia, move the structures in place, wire it. Yeah. The healing process is quite long.
I can imagine.
Is it where it has to be wired shut and everything?
Yeah, wired for
a lot of protein shakes for a while. Yeah,
but he's evidently ready for spring training. The news report, they announced it in the last few weeks. So that's
he's going to feel like a new man, right?
Yeah, maybe that's what with Ruth Bader Ginsburg falling asleep during the State of the Union. Maybe something.
That's a great point.
Someone should have Scalia could have slapped a CPAP on her in the middle of the speech. Just to...
Something tells me you don't want to be slapping anything on Ruth Bader Ginsburg. Hey, that's
that
a
might
great time.
Create a Supreme Court vacancy.
Let's take our first break because I think we're running off the rails here. We'll come back with more with Dr. Joe Ojile from Clayton Sleep Institute.
How we went from...
And we're back with more Eye on Health with Dr. Michael Jones.
That was the shortest commercial break in the history of broadcast radio.
Now would be a good time to mention you'll have some shorter breaks this show. More time for Eye on
Now
Health.
you're telling me this.
Yeah.
Okay, great.
Well, that's for the listeners' benefit.
Well, I had plenty of time to prepare for this show, right? I wasn't
That's
running
right.
late or anything.
I think there was a full 60 seconds before the opening sound.
He's a taskmaster, folks. Eric is pushing me a little too hard today.
Hey, it's time to step it up.
Okay,
over here.
all right, okay,
Yeah.
all right.
You've been doing this.
We've been off of Easy
18
Street now.
months
right?
now.
Yeah, right.
Welcome to the big leagues.
All right, folks, it is the big leagues, apparently, although it seems like AAA. This is Eye on Health every Saturday, 10 to 11. We're usually talking about health-related things. Your health, not Ruth Bader Ginsburg's health. or lack thereof.
We have to plan that show in advance.
Yeah.
One of these days.
That's right.
Yep.
All right, with us in studio, once again, world-famous Dr. Joe Ojile from Clayton Sleep Institute.
Thank you.
Sorry, my applause was a little low there. You got 2 rounds of applause, Dr. Joe.
Wow, I'm feeling good.
That's Clayton Sleep Institute. He does all things related to your sleep. He'll, you know what was really cool last time you were here talking about doing in-home sleep test. That was kind of interesting. But right before we went to break, I want to get back to Mike Napoli because I know you and I have talked about this. When I was in my medical training, and what I would still consider to be fact is when I hear sleep apnea, I don't think professional athlete. I think a 400-pound man who's overweight with a big, neck that collapses on him while he sleeps. But what a great example of you can be a relatively lean or fit person and still have problems with sleep apnea. And
it actually is quite common. And so, and I appreciate the opportunity to talk about this, is that the population that you were describing, this sort of in the textbook, a person who's obese and has a short, thick neck, those people are out there. The reason they're having obstructive sleep apnea is because their anatomy is set up, the back of their throat. So when they gained weight, it caused them to obstruct their breathing pipe when they sleep. What's being better appreciated now is how many folks have normal, they appear normal on the outside, quote normal. They're either,
whatever that is,
they're either close to normal body weight or maybe just a few pounds overweight. So it's not driven by the weight, it's driven by how the back of the throat was constructed. It's an anatomy problem. And so we use the analogy that if you have an injured knee or a bad knee and you're quite thin, the knee doesn't hurt quite as severely. But if you gain weight, the knee pain goes up dramatically. In the same way, the weight exposes that injured knee. The weight exposes the anatomy. So the rates of obstructive sleep apnea do escalate as you gain weight, but we're seeing more and more thin, good, healthy people who come in and they have obstructive sleep apnea undiagnosed.
And I guess that's why the treatment may be a little different. Let me just ask you this. If you are 400 pounds overweight with sleep apnea, something tells me that the jaw reconstruction surgery may not be your best option. Whereas if you're a 33-year-old professional athlete, the jaw reconstruction is a great option rather than nightly CPAP. And then let me ask you one more question. They're going to keep coming.
Yeah, that's
that's right. You got to remember the first part of the question. Then the second part is, if Mike Napoli has successful, jaw reconstruction, will he even need CPAP or anything like that?
The hope would be that he wouldn't, not knowing his personal case, but looking from the outside in, my suspicion is he's doing that so he hopefully doesn't need
it's a more permanent
it's more
fix.
permanent. It should be noted that this sort of surgery is really relatively uncommon. We don't see it done very often. While it's on the menu of options, especially in St. Louis, given the quality of the medical care we have here, even regular surgery for obstructive sleep apnea, while available. And again, the ear, nose, and throat physicians evaluate patients daily for this. The number of people who are getting surgery is actually declining very rapidly.
Interesting.
Because the actual overall success rates are limited, so it has to be highly selected patients.
Sure.
So we take a team approach. So you want to we have to work with the otolaryngologists, ENTs, and the patients to coordinate what their real goals are and what their odds of success are going to be.
Sure, yeah. So that's interesting. So as you said, it's got to be a very selected group of patients. So if you're out there and you have sleep apnea and maybe you haven't even been mentioned that there's some surgery, most likely it's because it wouldn't have had a success.
It's not going to be the likely.
Okay.
Yes, it's lower on the list of options.
So still then the standard treatment for the vast majority of these patients would be what we call CPAP?
Either positive airway pressure, so C stands for continuous positive airway pressure. The auto-adjusting one is called an APAP, okay? Then oral appliances are becoming very popular, and we like them a lot in the right patients. So typically mild or more moderate. And then combined with, if they need to, weight loss. So those are going to be the three most likely conversations we're going to have. Sometimes body position's an issue. So we can usually use that in combination, because people who sleep on their back, the back is usually the most disadvantageous mechanical position. So their apnea is usually worse on their back. So we always test people on their back, both to test them and to make sure they're fixed. So those are a few things.
What if what about the position of the bed? If the head of the bed is up a little bit and you sleep on your back, is that better, worse, or does it not really matter?
It can contribute to improvement if you elevate. Gravity does work. So, we frequently tell people as they age, gravity's your enemy, isn't it?
It is, yeah.
So, but in this case, gravity...
Obviously. He was looking... Why was he looking at me when he said that?
I was looking at someone who has not been affected whatsoever.
Well, Eric's over here. He's still in his 20s, folks.
Uh-huh. No ill effects of gravity.
Just you wait, my friend. Just you wait. Yeah. All right. Sorry, I didn't mean to interrupt, but
it's affected me. I was much taller. So that is an issue. Gravity will help. So that slight elevation or even a bigger elevation can contribute to a positive outcome. Yes.
And then I know you've been on multiple times, but maybe there's some listeners that don't know what, in a layman's definition, is sleep apnea. I know the three of us know what it is in here. Well, maybe the two of us do. I think he thinks he knows what it is.
Positive airway pressure.
But what is sleep apnea?
So the explanation we give every patient who comes in. So apnea means lack of breath. And so when they sleep, they have a lack of breath. And the most common type of sleep apnea is obstructive sleep apnea, where when people go to sleep, the tissues in the back of their throat collapse and either fully or partially obstruct the breathing pipe when they're trying to breathe asleep. And so they have to continuously, their brains have to be irritated and wake them up partially or fully to get a good breath. The most common structures that do that are the back of the tongue, the extra tissues that were around where the tonsils and the uvula and the thing that dangles down in the back of your throat, and then the nasal injuries. So there's a fair number of folks walking out there that have either sinus problems, or they've had their nose broken, or have a hereditary or congenital nasal septal deviation. So this gets to coordination of their care, but those are the most common.
So your throat or whatever closes off, lack of oxygen, that causes two things. One is that you can't sleep a full night because you're constantly waking yourself up, and you can't even help it, right? It's your brain waking yourself up saying, breathe.
It's to save you.
You're going to suffocate. That's one consequence. Now, surely there are other downstream consequences for lack of oxygen in these tissues. Is there any other problems that can happen?
So that's the key issue and why it's becoming so...
I am the smartest man alive!
I told you I went to medical school.
Second
He didn't. He's sweating. That was pretty good, wasn't it?
So the other things we worry about, right, which is a great thing to talk about, is, and this is why it's a public health issue, is it's a contributor for high blood pressure, heart attack, stroke, weight gain, irritability, depression, anxiety. It can contribute to, and then in each organ system it has some effects that we know of. We've talked about one. You talked about glaucoma. If you look at some of the listeners, for instance, about a third of people with high blood pressure have sleep apnea. If they can't get their blood pressure controlled, about 2/3 of those people, it contributes to atrial fibrillation, which is an abnormal heart rhythm. So people who have intractable congestive heart failure, the heart failure doctors now will try to, if they have sleep apnea, they will fix the sleep apnea to help them treat the congestive heart failure. So it contributes to helping the subspecialist do their work.
It seems to me, and I'm sure you'll agree with me because this is your specialty, but let's say someone has, an enlarged heart, congestive heart failure. It seems almost something they would have to be worked up for. Even if you're controlling that disease process, wouldn't you want to make sure that is it becoming more and more common that even people who may have well-controlled diseases are coming in and getting worked up?
They are. I think that's a great point. So I
won't hit the button again.
Okay, good.
But you know what I'm thinking.
I know what you're thinking.
Especially people with things like atrial fibrillation, the heart doctors want them evaluated just to make sure if they have anything to suggest it. If their spouse says they're snoring, if their neck's over 16 inches in a lady, 17 inches in a man, high risk anatomy or symptoms, they should be evaluated.
I'm close.
Yeah.
Is it? And I'm guessing because it is so essential to work these things up for those sorts of diseases. I'm assuming these are things covered by insurance. This isn't some sort of cosmetic measurement or anything like that. This is real medical problems.
It is real, and actually, to the credit of both our colleagues in medicine and also the insurers and / the payers, they want these things worked up by and large because there's such a contribution to healthcare expense, better outcomes in other disease states and so forth. It's become fully integrated in most healthcare practices and most healthcare plans. So that's actually an exciting development in the last 5 to 10 years from our perspective.
If you get someone on CPAP and you get their sleep apnea under control, it's a continuing thing, right? This is a chronic condition that they're going to have to continue to get positive airway pressure, correct? It's not going to fix itself?
The likelihood, so if they get on either the positive airway pressure or the appliance, they usually will stay on that for the foreseeable future unless something changes. So what can change? Some patients will, call it using it as a bridge. So they'll use their CPAP or their mouthpiece to bridge themselves to, if they are overweight, to lose a substantial amount of weight and to get in shape and to have better overall health. And one of the rewards for that is then we retest them. And many of those people at that point no longer have.
I see.
And then, so then they can come off. So that's an approach we take, which is very positive and optimistic to get health promotion.
Like a goal, right.
Exactly.
Yeah, give them something to work for. You don't want to have this Darth Vader machine in your bedroom go lose a few pounds.
Well, and on the other hand, I mean, if you're overweight, a contributing factor that could be that you're not getting sleep through the night, which makes it pretty tough to lose weight.
It's like a vicious cycle, right?
It really is.
Yeah.
You're seeing more and more of there's a lot of now these organized weight loss programs, bariatric programs, which from looking, again, from the outside in, are quite systematic. They have them go through dietary counseling, psychological testing, and all that before surgery. And usually sleep apnea evaluation is part of that.
Part of that.
Again, to help both safety-wise and to bridge them to lose more weight.
All right, folks, when we come back, we'll take your questions for Dr. Joe Ojile with Clayton Sleep Institute. Stay tuned for more Eye on Health.
What you need is on the menu and you get it tonight. Buddy, you got women's on your mind.
Welcome back to Eye on Health with Dr. Michael Jones.
All right, welcome back. Thanks for hanging on through the break. This is Eye on Health. Every Saturday, 10 to 11, we're talking about your health, sometimes your insurance, sometimes technology. And once again in studio, we have Dr. Joe Ojile from the Clayton Sleep Institute.
Point of order.
Yes.
ICD-10 code of the week, anything?
Don't push me.
Okay, sorry. All right, I'll leave it.
He is real. Dr. Joe can attest.
Normally, we don't make it till the third segment without an ICD-10.
Do they have one on for delivery of the fourth child?
Well, look it up. I'm sure they do.
Sure
yes.
I thought that's what you were going to pull out.
Well, we've got something here, but we've got more important things to talk about.
There's callers on the
We have lots of callers lined up to ask Dr. Joe about sleep problems. So let's get to some of your calls.
Okay. We've got Jerry on line one. Jerry, what's your question for Dr. Ojile?
Well, I have a lot of issues trying to sleep. I'm only probably about 10 pounds overweight. I don't know that it's sleep apnea. Obviously, it could be from hearing the conversation. But I think it started when I had tonsil cancer about 12 years ago. And on the right side of my neck had a radical neck dissection. So I couldn't snore if I wanted to. I've tried a lot of different sleep aids, sleeping pills, and they tend to work for 2 or 3 nights. And then again, I wake up at 3:30, my mind just thinking about all kinds of things and just can't get back to sleep. So I'm normally lucky if I get 5-6 hours sleep.
Jerry, are you tired during the day?
Sure. On those nights when I don't get sleep, yeah, you bet.
Falling asleep and so forth, or you just feel crummy?
Oh, just feel crummy, yeah,
Okay.
like I got the flu or something. I don't nod off.
Okay. Well, thank you for sharing your story, and I hope that your head and neck cancer is much improved or cured. And your story's not uncommon, and I'm glad you pointed out, because all of sleep medicine is not sleep apnea. So I'm delighted that you have several things. There's a couple things about your history and story that are quite interesting. The fact that you had that head and neck surgery. Did you have radiation, Jerry, as well?
Yes, radiation
You did. Okay.
and chemo.
Yes, sir. So that the surgical changes in your back of your throat, your jaw, and so forth, and neck can play a role in altering the anatomy as well as the radiation. So there is the possibility that you have this underlying low-grade, what we call sleep-disordered breathing, whether it's sleep apnea or not, where you actually stop breathing is unclear. That can contribute to some of your symptoms. However, your description of not being able of waking up, the medicine's not working for but a few days, and not being able to turn your brain off, I suspect you're solving all the world's problems, and we really appreciate you helping us. But in the morning, they continue to be there, and so
Can we get him on the government payroll?
So, what we suggest, and then this was described very well by the National Institute of Health's consensus conference in 2005 on insomnia therapy, is you need more than likely some comprehensive sleep behavior care. We have sleep behavior people who will sit and talk to you about all the aspects of your sleep and give you strategies. Actually, sleep can be learned, how to start and go to sleep, and how to handle that during the night. So it's called behavioral intervention, some behavioral therapy. If depending on how it's done, it can even be called cognitive behavioral therapy, but it's very effective. Nothing's, of course, 100%, but it's quite effective, and it'll give you the skills, hopefully, to both get to sleep now, and then if this happens again, say in 3 to 5 years, it'll allow you to be able to do the same behavior. So the goal here is, if you remember the old biblical tale, instead of giving you a fish, teach you how to fish. And so it sounds to me like that's at least partially something that's missing.
Now, is that type of therapy also covered by insurance?
Yeah, yes, it usually is, and so it just involves visits to the office. As far as the insomnia and the behavioral therapy, there's not any nighttime testing that's involved.
Gotcha.
Jerry, thanks for your call.
Yeah,
Thank you
thanks so
for
much,
sharing
Jerry. Before we go to the next caller, he brought up a couple of good points, and I'm sure this is the most common thing. I think his sleep problems were multifactorial,
Yes.
right? It wasn't just a physical obstruction, but also he couldn't turn his brain off type of thing. That was one point. So great question, Jerry. And then one other thing I noticed, nowhere in your answer did you say we need to dope you up on medicine to try to get you to sleep. And I think you've talked about that before. These behavior modifications may work better.
They do, and then, the other thing is what we tell patients is we're agnostic about medicine. If they need it, we want to use it as part of the solution, but not usually for the complete solution, and not long term.
Great. Next up, we've got Susie on line 3. Susie, what's your question for Dr. Ojile?
Hi, I do have sleep apnea, and I was tested at Clayton Sleep Institute by another physician. And they discovered that I stopped breathing 27 times every hour. So that was a red flag for me. So I am on CPAP. I've been on CPAP for about 9 months now, and I love it. I found a couple really good things about it. One is that I have not had one single incident of acid reflux since I've been on CPAP. And the other thing, besides the fact that I'm sleeping, is that my husband is also sleeping, which is a wonderful thing. But my real question for you is, we are preparing to take a 2-week trip to Ireland in June. And I'm planning to take only one small carry-on bag, and I don't see how my CPAP is going to fit. I've seen some on the Internet, some very small versions of it, but they're quite expensive, and I'm wondering if an anti-snore appliance made by my dentist would get me through the 2 weeks that we are overseas.
Well, thank you for calling in.
Yeah, that's a great question, Joe.
Is.
I've been wondering the same thing. How do you travel with these things?
So that's awesome. And first of all, thank you. I hope you had a great experience at the Sleep Lab with my colleagues, and appreciate you going through the process and being positive and optimistic about your therapy, because that attitude will translate into better outcomes. On the specific questions, there's a couple things. One, snore guards typically won't fix your sleep apnea. They may make you stop snoring. Some people will actually purchase through their dentist the actual oral appliance that you use for obstructive sleep apnea, and that is a solution. But if it's only for 2 weeks this one time, it's somewhat of an expensive solution. The smaller machines, they're probably one of the best ones that's out right now, and this isn't any sort of endorsement. It's just one that's quite popular, and we've seen good success with it. It's called the Transcend, and it's about $500, I think, and it does not have a humidifier. So that's one thing. If you can get by without the humidifier, some of these smaller devices are available. But here's one other solution that we have not talked about. There's a thing called nasal valves. What they look like is they're small Band-Aids that fit on your nostrils. They're one-way valves. So when you breathe in, it pressurizes the back of your throat, and it does the same thing as CPAP. So they're FDA approved, but not covered by insurance typically. The original name was ProVent. If you want to look it up on the internet, ProVent. They're also called TheraVent. So they're available. They're there we have them there as a service for patients, and the most common time we see these used is for travel. So they can be quite effective, and they can apply 7 to 9 centimeters of water pressure typically, which I don't know what your CPAP pressure is set at, that we measure it in centimeters of water pressure. Do you happen to know?
No.
Okay. But the most common pressures are 6 to 10. So more than likely, this would be a possible solution. And you might want to talk to your sleep doctor or to the respiratory therapist there at the Sleep Lab, and they can give you all the information as well. And that may be another opportunity where you wouldn't have to take your CPAP at all for those 2 weeks.
Probably less expensive too, right?
Quite inexpensive actually in comparison.
Oh my gosh, that would be wonderful. Thank you very much. I appreciate it.
Thank you for your kind call.
Thanks for the call, Susie. Yeah, what a great point. I've wondered that because this has got to come up all the time.
It does. It comes up a lot. If you notice now, patients, first of all, if you go to the airport, they have a sign that says, if you have CPAP, at security, if you have CPAP, please put it on this part of the belt and whatnot. So the screeners are used to seeing them. They're so common. What patients tell me, and I apologize for not having official confirmation from the TSA, but evidently your CPAP device does not count as your carry-on.
Oh, okay. All right. So you're not going to get charged extra for it.
That's what I've been told. I haven't heard that from the airline, but patients repeatedly have told me. Okay. Thank you for the question.
Yeah. All right. We've got Tim on line 2. Tim, what's your question for Dr. Ojile?
Hey, Dr. Ojile, it's Tim, one of your former patients. It was about, I want to say, 2008. I was at your clinic.
Oh, great.
Yeah, it was a while back. Anyways, you're so kind enough to me. You took me in. My mother, I didn't have insurance at the time. I was poor and all that. But you were my dad's my dad was a former patient of yours.
Oh, thank you, Tim.
You were very kind to me and taking pity on me. I didn't have any money or anything. But anyways, I'll get to the point. I weighed about 412 pounds. Woke up more than 1,000 times in the night. And
wow.
You put me on a BiPAP machine. It works great. I've lost all the weight. I'm about 230 pounds right now. And doing well. And
congratulations.
I actually achieved REM sleep. And I'm not waking up maybe twice a night due to my baby, taking care of my baby. But that's normal. I'm not having any trouble other than having a dry mouth occasionally. Do you think I should stop using the BiPAP machine? Because I haven't used it in about a year now, and I haven't had any complications.
So Tim, thank you. Thank you for such a really great history and story, and I want to congratulate you on taking such a positive, proactive part of your health. You've lost 200 pounds. You lost an entire person in weight. So that's really neat. I will just share that these callers, we always tell people that they come in for us to lift them up. They lift us up. You inspire us to do our work every day and help. I would suggest, especially with the congratulations of your new child, probably a simple maybe home test to make sure that you do or don't have obstructive sleep apnea ongoing is a very easy, cost-effective way just to double check. You do have that anatomy and that risk. You probably have marked improvement in your sleep apnea, but it'd be unsure just based on what you're saying if you have it or not. So I think just to be safe, especially for your long-term health, and now that you're a dad, it'd be a good thing to do. Congratulations.
All right, guys, stay tuned. More with Dr. Joe Ojile here on Eye on Health.
Wow.
There's a time and place for everything.
And we're back with more Eye on Health with Dr. Michael Jones.
You're killing me today, Eric.
Hey, listen, I'm trying to give the listeners as much Dr. Jones and Dr. Ojile as possible.
Normally, I've got time to go take a break and get a drink.
Not so.
You're killing me.
1 hour a week, Dr. Jones.
What did I
You
do?
are on my time.
And that's very true. And of all the weeks, I'm running late. Dr. Ojile's here, and you're pushing me.
Well,
welcome back to Eye on Health, folks. This is almost like satellite radio. There's no commercials here. This is great.
What's that? I've never heard of it.
Oh, yes, right.
That's right.
We've got Dr. Joe Ojile from Clayton Sleep Institute talking about sleep and how it affects your health. We have had just some remarkable callers. So
wonderful calls. Thank you.
What's great about those calls, those are real world sort of things. Mm-hmm. And I'm sure if there's one caller, there's 10 other people who are having the same experience. So thanks so much for the calls. We're coming to the end of the show here, but let's try to get to as many of these callers as we can.
Yep. We've got Ron on line 1. Ron, what is your question for Dr. Ojile?
I've been on a CPAP machine for about 6 years. It's working fine. It does what it's supposed to do, but I really don't like the inconvenience of it. So I'd like to know about the efficacy of these appliances that you can use in your mouth. I see lots of them advertised now through dentists. They'll make you one. I don't know what they know about it. I'm also was enchanted by the ProVent, and I'm wondering if that might be a possible solution for me full-time. My sleep number, I think it's 10. Mm-hmm. And then I'd like to know whether or not this is covered by Medicare. And those are my questions.
Great. They're great questions.
Thanks, Ron.
Was this a truck driver?
No, that's another question coming up. Yep.
So there's several. Let me talk through the subjects quite quickly. And this is a very common reason for someone to come in and have a visit, by the way, sir. So thank you again. One, the appliances can be very effective. Especially if your severity of sleep apnea is in the mild to moderate range, we actually talk to every patient, if we can, about that as an option. So patients have different goals. Usually you want to have your teeth. So if you have full dentures, most of the appliances can't be used with the dentures, from what my dental sleep colleagues will tell me. We do have access to very good sleep dentistry or sleep dental care here in St. Louis, and so an evaluation is usually appropriate and helpful. You should have a test done, even just a home test, in the year prior to getting evaluated. They're going to want that data to assess your severity of your sleep apnea. So you might be a candidate, but there's not enough information to know whether that would be the case. At 10 centimeters of water pressure, the ProVent could be an option for you, but since it's not covered by health insurance, you end up having to buy it each month. And so you'll have to make that economic calculation as well. There was a third part to his question. I
think you got them all.
Was it Medicare?
Oh, Medicare.
Oh, Medicare, yeah, right.
Your dentist would work that out with you, but my understanding is that Medicare does cover the oral, they're called oral appliances or mouthpieces for some patients. So that is a conversation that you should have. So good luck, and if we can help, we're happy to, sir. Thank you.
Before we go to Eric here, who has another question, not this Eric. If you have a question, we've got a few minutes left in the show. We might be able to get one or two more in. Give us a call, 314-969-9797 or 866-455-9797. Eric, you are on the line with Dr. Ojile. What's your question?
Thank you. I'm a truck driver. I'm 6'4", about everything between 375 and 400. Well, I'm losing weight, but every time I get a DOT physical, they want to say I have sleep apnea. I have no problem sleeping. I never lose my breath or whatever when I'm sleeping. I sleep good, but the thing is, I don't sleep flat because I had a car accident and I hurt my back, and I lay flat. I can't sleep at all because my back hurts, so I sleep in a recliner.
Okay.
I was wondering why, no matter what, just because you're big doesn't mean you have sleep apnea.
Yeah. So this also comes up commonly, and by the way, we're very thankful that you called in because this is an important subject. So. For people who operate motor vehicles for a living, and actually anyone who operates a motor vehicle or heavy equipment, generally, safety is going to be a significant concern. So what the examiners are doing, and they're under a lot of scrutiny. There's regulations and so forth out there that give guidance to this. Is they want to, as all of us as citizens in this together, because we're all on the roads together and so forth. We're trying to improve safety, and so people that have high anatomic risk. That doesn't mean that you have it, just high anatomic risk. So if you're a male and you are over 17 inches around your neck, if your body mass index, which is a combination or calculation from your height and weight. Some people will say over 30, some over 35. And if they look in your throat and you have a small throat, that would be considered high risk. So they're not necessarily trying to unpick on you in any way. They're just saying, okay, we need to make sure that this individual who's going to be operating some sort of motor vehicle, which effectively, if they fell asleep, would become a dangerous event, it doesn't have that. So it's to protect both you and the public.
But wouldn't you think rather than just telling him he has it, shouldn't they send them to someone like you so he can get actually tested for it?
They do. No.
Okay.
So what happens is that causes them to have to be evaluated by a sleep clinic or a sleep doctor. And so that's kind of the process.
Well, if I have to go to sleep studies, do I have to sleep in a bed or can I sleep in a recliner?
It depends. We do have some of that available, or elevated beds. So it depends.
I have to have elevated. I cannot sleep at all laying flat in my back.
Because you have back.
My knees start hurting.
Yeah, so there is the possibility of sleeping in a recliner. One last thing is people that have chronic pain are frequently on pain medications, and that actually can contribute to making obstructive sleep apnea worse or cause another kind of apnea. So that's another reason to look at it, sir, as well. So you may not have anything wrong. I can't tell from your history and wouldn't dare say, but I think an evaluation would be helpful.
That's a great call.
Yes, thank you.
We get those calls all the time, and sometimes we don't have enough time to get to them. So it's a great call. But you're saying you normally would check someone flat, but if their normal sleep position is upright in a recliner, would you then do the test in that position?
We will attempt to do that depending on the circumstance. He has a medical reason that he can't lie down, so that's a bit, but we have people that have heart failure, things like that become quite physiologically complicated. So we have to adapt to them.
Well, thanks so much for coming in, Dr. Joe. It's always interesting to have you in. We'll have you back again.
Great,
thank you. It's fantastic. Thanks for tuning in, guys. We'll be here next week too.
We'll be here next week.
Thanks for the great questions.
Yes, thanks.
Get more at 971talk.com.